Welcome to Invisible, Breaking Through the Stigma of Addiction. I'm your host, Dean Anderson, and on today's show, we have Dr. Martyn Judson on the show. Thank you for being on the show.
Pleased to be here. Thank you.
Last time we were on the show, so I'm going to give a quick recap to the audience. We talked a little bit about who you are. We're not going to spend a lot of time about that today, but so those who don't know, is Dr. Judson is an addiction doctor, been in the city for decades, one of the pioneers of the methadone program here in the city, and has worked in the addiction field ever since that, so many, many years. So he's an expert, so to speak, in those things. He helps out at the University of Western Ontario in the medical program and doing teaching and education. So I think I'm missing, I'm sure there's so many more things.
No, that's about it.
That's about it. So he's here today because the last time we had a conversation, right towards the end of the conversation, we got onto the topic of safe supply, and recognizing the need for opiate antagonists and those type of treatments, that there's probably much more to safe supply than what we're talking about. And I wanted to have a conversation about that and whatever else comes up, because I would love to just kind of go off into the tangents of what's happening in our city and the future of addiction care.
Well, it's not just in London that it's a problem with opioids. It's throughout the country. In fact, most of the Western world is suffering from problems with opioid misuse and overuse. But there have been so many more clinics open up, particularly in London, prescribing opioids, in my opinion, quite indiscriminately, that it's contributing to the problem and not relieving it. They're called supposedly safe supply clinics, and I think you just got to look at that. What does it mean by safe? Well, it's very limited. Those who've started these clinics say that it's better for those who are suffering from opioid dependence to be prescribed pharmaceutical grade opioids that are not contaminated, and therefore there's little risk of overdose from the combination with other substances, and that the medications that they're taking in some way haven't been adulterated with certain infectious diseases, for example. So that was the intent, that it was encouraging people to get prescriptions from a physician rather than go to the street. And that's why it's called safe. But the downside is that it isn't safe, because many of these clinics are prescribing the very type of medications which are in actual fact aggravating the disease of addiction. And in particular, when you look at the methadone program, we started some 30 years ago, that was in response to the surfeit of Percocet tablets that were available, and the introduction of methadone clinics helped considerably in sort of bringing that under control and reduce crime rates and so on and so forth. But then when we had the surge in hepatitis C and HIV, it was thought necessary to have more options available to patients, because admittedly, not everybody is comfortable or wants to experience the rules and regulations and protocols that they must follow if they go to a methadone clinic. So alternatives were introduced, and one of those was what is called these safe supply. But it's not safe, other than it being pharmaceutical grade opioids that they're prescribing. It's not safe because the wrong type of opioids in most of these clinics are the ones that are being prescribed. And that's the patients are being prescribed short-acting, in particular hydromorphone, which is ingested by mouth and causes a fairly rapid rise in the opioid level, and then it's metabolized, and then the blood level falls, and so that sort of effectively on-off phenomenon encourages destabilization of the brain, which is the one thing that methadone encourages. So when you've got the fluctuating blood levels of an opioid, that's causing people to be content with their dose and then go into mild withdrawal after about sort of 5 or 6 hours, and then they go in search of something more. And so if they've been given a prescription for maybe a day's supply or even a week's supply of the dilaudid, they may well ingest most of that in one day, or if they feel they can be reasonably comfortable on the day that they get the prescription, they'll sell the balance and then go and buy street fentanyl, or it may be they have access to pharmaceutical fentanyl. So it's not safe insofar as it's not doing the nervous system any good. And it's not safe because it is in actual fact encouraging diversion. And we've seen over the last 15 months that the opioid overdose deaths in the city have been increasing. But that goes in tandem with the fact that there are more and more of these clinics and more physicians prescribing. I wouldn't object to long-acting opioids, such as long-acting morphine, which has come under in the name of Meslon and Acadian. These have been offered as an alternative to methadone for many, many years. There's no harm in that being offered, but to give patients short-acting opioids is in actual fact aggravating the situation. It's not helping. So, and the other issue with it as a problem that is that the prescriptions are issued for a day or a week, as I said moments ago, but it should be that it's dispensed daily. Like patients who are new to a methadone program are not stable in their lifestyle, and their addiction is not in the slightest bit under control. So to help them, they need order and regulation, and that's why daily dispensing of the medication is of paramount importance. But again, a lot of patients are on this supposed safe supply, are going to the pharmacy, and maybe they have one witnessed dose, and then the rest they can take out of the pharmacy and use prematurely before the time that is meant to be the interval after the previous tablet, or they're selling it. So I don't like the term safe supply. I think supplemental supply is a good idea, because for some patients, those opioids that they're getting on prescription may supplement the methadone that they're getting, because when patients are initiated on methadone, they can't go into therapeutic dose immediately, because there's a risk of respiratory depression and overdose death. So the dose has to be titrated up gradually. And all the while it's being taken up slowly, the patient is still experiencing some withdrawal. So it may be a good idea to supplement with morphine, which doesn't cause such significant respiratory depression, but to give them short-acting opioids. Yes, it will supplement their need for opioids, but it's also doing it on a sort of off-on manner, and that is, in actual fact, making their withdrawal symptoms worse rather than better.
What it reminds me of is I see a lot of people, and maybe this for the audience who doesn't understand the opioid or the short-acting versus long-acting, I see in today's world there's a lot of people using vaporizers instead of cigarettes. And you see a person who would go out and smoke a whole cigarette, and they'd smoke them once an hour, hour and a half, and they'd smoke a whole cigarette, and then they'd have this dose of nicotine that would be in their body. Whereas now we're recognizing people are using vaporizers, so they get this big puff, but it's a little short acting, so they take 2 puffs instead of smoking a whole cigarette, but then they're puffing every 10 minutes.
That's exactly the same thing.
And that process is like, oh, and then they just can't get that thing out of the, so it's causing a more of a dopamine trail, or that tracking of biochemical,
right.
And it pulls them through. So now they're smoking twice as much. So if they stopped using the vaporizer, they'd have to smoke twice as many cigarettes to get that sensation or that use out of it.
That's correct, yes.
Yeah. So I see that as being a concern for obviously overdose then, or if you're using short-acting, and then you go and use your regular long-acting stuff. Is there a potential there for misdose, or?
Yes, because the more opioid that you have in your system, the greater the risk of the overdose. Mm-hmm. But it must be emphasized to patients that they can't feel better immediately. There's always a sort of time delay. Mm-hmm. And during that time, they need to be supported and seen frequently by their physician, and have the dose of, say, methadone or buprenorphine titrated up. But if they get used to sort of taking short-acting opioids, then that's going to make it more difficult for the methadone dose to be the ideal dose of methadone to be identified as quickly as it could be. And so it often means that the patients will end up on a higher dose of methadone ultimately, and all the while they're taking ever-increasing doses of opioids. Not just those that are prescribed, but they're accessing more from other people as well. Mm. And then the danger is that if patients have been used to taking all these supplemental doses of opioids and then stop and then return to that sort of service because they forget their dose of methadone, they will then probably suffer a risk of overdose because they've lost their tolerance to those opioids, which they were taking in greater amounts than they should have done.
Okay. Yeah. I see that with the overdose risk for abstinence programs or people going through, spending time in jail or getting out and their tolerance decreases, and or being in the hospital for lengthy periods of time and then having an increase.
That's the greatest risk of relapse, is when patients have been absent from opioids for anything more than sort of a couple of days, and they may self-discharge from a hospital if they've had to go into hospital for some reason, and they can't get their regular supply of opioids. Their tolerance has gone down, and as soon as they leave hospital or they come out of a withdrawal management center, they go to their dealer and they say, well, I was on X number of tablets before I went in. I want that many again. And of course, that proves to be too much, and that's what kills them.
Yeah, unfortunately, I've seen that. The safe supply, would that be beneficial in the role of preventing that? So if somebody didn't have access, then they have that constant using. So would that impact? What I'm trying to say is if I'm using the safe supply and I have the hydromorphone and I'm using every day, opposed to having time off when I don't have money or time off when I'm stuck without, and then I get some money and then I have a risk of overdose, would that, essentially decrease? Because I don't know the statistics on overdose. I know the Suboxone statistics then they're almost gone down to zero.
That's correct. You really can't overdose on Suboxone. That's why it's really very safe.
I don't know where that sits. I don't know where the statistics are.
And this is the danger. If you have one physician prescribing methadone, and unbeknownst to them, they're accessing opioids from another physician, which is really to treat the same condition, namely opioid dependence, you in essence have two doctors treating the same condition with different medications, one methadone or Suboxone and one hydromorphone. That is just not good medical practice.
So there's no regulatory body that keeps track. So I could go to 3 different methadone clinics, or I could go to, Safe Supply, or go wherever.
The only way in which that could be tracked is if the patient goes to the pharmacy, and then it would come up on the patient's profile that they're already they're already accessing opioids from another physician. But sometimes that can be delayed. It can sometimes a physician who's prescribing one of those medications can't be contacted, and sometimes it's not very helpful because of the lack of communication. But any physician who's prescribing an opioid should always check when the patient had their last dose of that particular opioid, because opioids, the patient will lose tolerance to opioids quite quickly, but they lose tolerance to methadone more quickly than other opioids. But no matter what, if you're on, suppose, this supplemental supply and you've gone several days without it, you can't go back and be prescribed the same amount. And that's why it's essential that anybody who's on a supplemental supply, which the physicians who write those prescriptions call safe supply, it should be observed, witnessed doses on a daily basis until the patients have proven their stability. They're not using multiple other drugs, and so they've demonstrated that responsibility that deems it safe for them to take home doses.
So if I understand this correctly, in the methadone program, in order for them to get their dosage, they need to do drug testing?
Yes, the drug testing is not 100% accurate, particularly the tests that we do at the clinics. If you want, that you could say they're probably around about 95 to 97% accurate. You get some false positives,
which is more accurate than I am most days.
Correct. But if you send that sample of urine out to a commercial lab here, and we have a couple in the city, which say that the accuracy is about 99.8% accurate. But those are expensive tests, and it takes about 4 or 5 days to get the results. The advantage of doing the tests in the methadone clinic is that you have the result within about 4 or 5 minutes. But a negative test in the clinic doesn't mean the patient is absent from everything. It just means that there is absence of evidence of active use of that particular drug that we're screening for on that particular day. And we only screen for about 4 or 5 drugs at a time in the methadone clinic. Whereas if you send the specimen out to a commercial lab, it can screen for about 50 addictive substances. So that's a more accurate way of determining. But for us at the clinic, it's just a guide, and if someone's test is positive, that's an opportunity to question the patient, not in an angry way, but just say your test is positive. Were you aware of using that, or can you explain that? And sometimes that helps the patient to realize that they are in actual fact purchasing contaminated, adulterated substances on the street, and it might motivate them to stop using that sort of source of opioids and just rely on their prescribed methadone or Suboxone.
So exactly as I thought, this conversation would just fly right off. And we're at a break time, so we're going to take a quick break. We'll be right back after this. Welcome back to Invisible, Breaking Through the Stigma of Addiction. And today we have, again, Dr. Martyn Judson. Thank you for being on the show. We're going to jump right into, like, I know we were in that conversation and we're talking about the logistics of treatment and talking about the logistics of safe supply and what it is and what it isn't. But what I'd really like to talk about is what that means for recovery. Like, I mean, because there's a difference, a big difference between putting a Band-Aid on things versus trying to heal and grow. And I think there's a big difference there. So, and I know that off screen, me and you have talked about, what's missing in the idea of safe supply or some of the treatment methods that are happening today in the idea of recovery. So I'd love to hear your view.
Well, I think the big problem is that in North America and spreading throughout the world is that this notion that addiction is a brain disease. I've always maintained that addiction can be classified as a disease, and that has its advantages because it helps to reduce stigma, and it gives patients hope and promotes a sort of management or treatment outline, and it absolves patients of their sort of beliefs about their own past mistakes that they've made. But the downside is that it has really encouraged physicians in particular to believe that there is only one line of treatment, and that's with the prescription pad. In my opinion, there's only 1 or 2 medications that are useful in the treatment of addiction, one being methadone, and that has without doubt proven to reduce harm to society and promote health. And the other drug is its sort of a safer successor, buprenorphine, which is perhaps better for those people who've got better recovery capital. They're not so advanced in their addiction, although that's not 100%, but in general, that's the difference between the uses of the 2 drugs. But by prescribing these medications, it's encouraged people to forget what true recovery is. And the medical profession and a lot of other people believe that recovery is abstinence. And so many medications will be prescribed in the hopes that it will persuade patients from using drugs. But you're just switching a street drug, as it were, for a prescribed drug, and that's not necessarily the answer. Recovery begins with abstinence, but view it as that abstinence is the ticket that you buy to get into the ball game of recovery. So once you're abstinent, then recovery begins. And recovery really has very little to do with being abstinent. Recovery is being able to develop a routine, to get rid of the chaos, to start to build your self-esteem, to develop responsibility, to develop accountability. Because addiction, is known as the great remover. In the case of alcohol, it will take away the stains out of your clothing and carpet. It will take away money from your pocket. It will take away your friends. It takes away your health. Eventually, it takes away your life. And the same thing is often the case with other substances. But what needs to be put in place when you take away a substance that someone is misusing is that they've got to have routine. They've got to get away from the chaos that's been, or the routine that's been taken away from them by drug addiction, and you've got to replace it by their own self-styled routine and regulation, and to a degree, an element of self-discipline. And once you have that, then patients start to feel better about themselves, and that makes them want to do more, because nothing succeeds like success. And once patients can see that there is an alternative to using, then they become self-motivated, and they almost become almost high on life, and they just want to get more out of all the good things that are offered in life. And unfortunately, many people who suffer with addiction have never known the potential that they have, but that has to be over time explained to them. But that they can't stand any chance of achieving that without having first become abstinent.
Abstinence, in the last 10 years that I've been doing this, seems to be a bad word. Like when you say it in certain circles, it's like, oh no, it's controlled use and harm reduction, and you'd be surprised at how often it comes up like abstinence-based programs are going against people's human rights, or the idea of making me do something I don't want to do.
Well, I always emphasize to people that recovery is a voluntary program. You don't have to do it. You're not forced into it, but you've got to let people know that they're all, just as there are no two identical addicted people, there are no two identical paths to recovery, but there are different ways of achieving it. Some people recognize that they just want to stop, and they grapple with that idea, and then eventually it's not some big catastrophe that happens. They just get up one morning and they see a half-empty bottle of wine sitting on the countertop in the kitchen. They just say, I've had enough, and they move on, and they don't seek treatment or help in any way. In fact, 80% of people who meet the definition of being addicted do not consult anybody. They don't go and see a clinician, a therapist, a counselor. They don't go to any support meetings, mutual support meetings like AA and NA, which have done amazing good for those who go. But there are many people who, 80% will just stop on their own. On the other hand, there are those who seek help and advice and guidance. And that's up to a counselor to lay out all the possibilities that are available. But the patient in return has to be somewhat eclectic and say, yes, I will do that, and I'll do this, but I can't do that. And they then sort of come up with their own recovery program that fits into their lifestyle and what's available. For example, some single men can go off to a treatment program where abstinence is expected, but a mother, unmarried single mother of 4 children, can't do that. So they have to come up with an alternative. So the idea is that you have a negotiation which involves the counsellor presenting the alternatives and the patient selecting those things which are possible and feasible for them to do. And one of them might be that they don't have to be abstinence, but the less drugs that you have in your system, the more it's likely to get better. So if you're striving for recovery and you're teasing your brain with the memories of using by continuing to use, you're really making it harder for yourself. So yes, it's better to be absent, but that doesn't suit everybody. And that's why I think abstinence has been viewed as a bad word. And I often say you don't have to stop cold turkey. You can do it warm turkey. You can wean down over any months that you want. Whatever you choose, it's your recovery program. You're likely to invest more effort into it if you design it, if you produce it, and you star in it. It becomes a blockbuster. So you do it your way. But there are sometimes what you're doing may not be quite right, and that's where a counsellor can intervene and just tweak that a little bit and try to get you to focus on a more appropriate path.
I often refer to myself as a simplifier. My job is to take complex things and make them simpler for you to understand and give you the options to go in that choice and move in that direction on what you choose. And it's my job to make it sound right to you and using your language and the things that you do to do
That's
that.
absolutely right. And that's one of the appealing things about entering addiction medicine. I, having spent sort of 10 years in general practice, which was really catering to the worried well, and patients keep on coming into the office with the same old problems. But I noticed it was the same inability to understand why they were not getting well. And it was because of the environment in which they were working, the people they were living with, the work they were engaged in. But they were in denial, and that's a characteristic of for people who are sort of psychologically not well. They tend to minimize and deny that they have a problem because change is too painful. But once they realize that change is possible, then they were the ones who initiated everything. And I found that I didn't really have to do very much work. I just sat there and saw them demystifying their problem and turning their complex lifestyle into one that was much more manageable. And I could see that they were the winners and I was just going along for a ride. So to me, a career in addiction medicine has been very, very satisfying and far less sort of draining than general medical practice.
Even though they say that working with people with addiction has a high burnout rate, and usually there's lots of frustration and worry and fear and hazards and
yes, I can see that. But I think there are many people who go into addiction management or treatment. I don't really like the word treatment because it's endorsing this disease model.
Okay, yeah.
Bearing in mind that it's not just a disease; it's also a learned pattern of behavior. Mm-hmm. But if you can. If you go into treating people who are addicted, you've got to look at the reasons why you're doing it. And bear in mind that 40% of nurses and doctors and healthcare professionals in general come from an addicted family. And so many of them are going into that sort of line of work because they want to do good or think they've got the answer from their own personal experience. And maybe it's because it's this day and age somewhat chic to be in the addiction field, but that's leading to a lot of people going in who are not really suited to be going in, and they're going in because they want to be sympathetic and supportive, but sympathy has no place in the treatment of addiction. Empathy does. Correct. But not sympathy, because otherwise you end up with two sick people, and the addict or the addicted person, should we say, always brings down the over-sympathetic counselor or physician. And that's why I challenge a lot of physicians to not go into treating addiction until they're well established in recovery, many years of abstinence, and they've gained insight into their own psychological makeup. Then they're able to withstand the demands of a manipulative person who's still active in their disease of addiction.
Perfect. Thank you for being on the show. Thanks for all that wisdom and that great information. And hopefully there's a lot of people out there listening to it and taking that home. But recovery is not just a medical problem. And I think we've determined that. I thank you very much for being on the show again.
Thank you for the invitation. I hope it helps.
Thank you for watching Invisible, Breaking Through the Stigma of Addiction. We'll see you next time.